Problem.
C'est Nastico qui parle. C'est ce qu'il m'a dit, Nastico.
Hi, everyone. Good evening. Hi, good evening. Hi. Great to see you all. So I will make it short because we have a very, very important topic today and a great guest. It's great to see you from all over Europe. I have a guest from Germany that I invited because I saw his presentation. He's actually like in the same, we share one workspace. Actually, I've seen his presentation. Maybe everyone could mute themselves for a second. Thank you. And I think he has done some great research on the topic of vaccination. And I'm very glad that he's going to share it with you. He puts a lot of effort in it to translate everything to English. So I'm very grateful for that. I really hope to have a good discussion with you. If you have questions in between, just ask them through the chat thread. And we can have a discussion afterwards. For me, it's just important that we keep this discussion out of the Facebook group, because everyone knows we are not alone on Facebook, and I want to prevent that the Facebook group is in danger and shut down. So please, if you have like something to discuss on the topic of vaccination, please don't do it in the Facebook group, because I will have to delete it. But let me know and I will arrange a meeting like that and we can have our discussion, but just outside of the Facebook group. Now I will invite Florian Schilling from Degename. Maybe you can say a few words about what you do, what's your focus area, and then we're very curious what you will show us about the vaccination.
Okay, so hello everyone. I'm glad to talk to you today about this topic. I think we urgently need some more information about the ongoing vaccination campaign. I am a health practitioner, so something like an ND here in Germany. I am practicing since 2006. I have mostly focused on integrative oncology, and the last years I spent in Asia to set up some facilities and clinics for integrative medicine, functional medicine with focus on oncology and neuroinflammation. Since 1.5 years, I'm back in Europe, in Germany, and currently I work as a Chief Knowledge Officer for care in Munich. So my job is to do research, evaluate existing protocols, update them, let's say kind of translational research, and to educate and teach other people, other colleagues about integrative and functional medicine. I'm also heavily involved in this Corona topic. We have kind of an integrative medicine board here in Germany, and I work for 2 of them. So I have tried to provide solid information about this Corona topic from the very beginning until now. And since 2 months, I have done a lot of research on this vaccines. And I've put together, let's say, the crucial information, the core information that I think everyone should know. As Corinna mentioned in the beginning, we are facing very hard times with this topic, because in the very moment that you criticize, or let's say, even if you are a skeptic, you don't criticize, you are a skeptic and ask questions, you can run into troubles. I have seen this here in Germany. A couple of colleagues are doing YouTube channels, Facebook groups, and so on, and few of them have been shut down. Not because they spoke against the vaccines, they just had some doubts and had some questions, and that was enough to be banned by social media. So let's be happy that we have this forum this evening. I will not emphasize on political stuff or legal issues. That's not the task today. I just want to show you information from the phase 1, 2, 3 trials from the vaccines that were done by BioNTech, Pfizer, Moderna, AstraZeneca, and Johnson & Johnson. It is not easy to go through those publications. As you will see, They publish a main paper with about 10 up to 15 papers, and all the nasty stuff, all the interesting information is hidden in the appendix. And for example, with BioNTech Pfizer, you have 14 pages of primary publication that was also published in the New England Journal of Medicine. And you have about 700 pages of appendix. And if you want to learn about risk assessment, toxic effects, side effects, you have to go through the appendix. You will not see it in the main publication. So I spend a lot of time to read all those appendices with almost 2,000 pages now. And the most important information of this I want to share with you today. At the end of the lecture, we will discuss some options, how to deal with a vaccination. Let's say if you have a patient or a customer that does want to do the vaccination, and there might be reasons for individual situations to do the vaccination. I'm not completely against it. So if you have someone facing a vaccination, or if you have to do a vaccination on your own, this is something that will happen in the near future. I think that everyone working in the medical business as a clinician, as a physician, will have to do the vaccination. This will become mandatory very soon. So also for us, we need to have an idea how to protect ourselves and go through this vaccination health and safe. Okay, that's all I wanted to say in the beginning. Now I will try to make the presentation running. Okay. Can everyone see the presentation screen?
Yes, we can see it.
Okay, beautiful. Good. Then let's start. At the moment, we are going through the biggest clinical trial of all times, what we call a rolling review. Actually, what is happening now is kind of a weird phase 3 clinical trial. And before we go into details, I want to share the basic principle of the different vaccination techniques with you, so we all have the basic knowledge we need to deal with this topic. So the general principle is rather easy. We present an antigen, which normally is taken up by our phagocytes, mostly macrophages and dendritic cells. They will process the antigen and present it to our specific immune cells, the T lymphocytes, that will develop cytotoxic CD8 lymphocytes, the so-called killer cells. The killer cells' main job is to eliminate infected cells. The second population is the B lymphocytes. They will differentiate into plasma cells and then build antibodies. Job of the antibodies is to eliminate the virus before it can enter the cell. This is an important difference because antibodies are not capable of dealing with infected cells. So as soon as the virus has entered our cells, antibodies become useless. If you want to deal with this situation, you need the cytotoxic T lymphocytes. And this might be one of the problems we will face in the future, because most of the vaccines induce a Th2 immunity, meaning that the immunity mostly relies on antibodies. A natural infection with COVID-19 mostly relies on cytotoxic T cells. This is what I see with my patients here in Germany. If we do immunity profiles after they had disease, we see antibodies in about 30 to 40% of the patients, but we see a T cell immunity in more than 80% of the patients. So obviously our immune system prefers to deal with this virus with specific killer cells, not so much with antibodies. So far, we have relied on different vaccination technologies. Historically, the oldest one, the first one, is to use living microbes, so-called attenuated vaccines. We have done this with smallpox, very successful, polio. We do it with MMR, and we still do it with TBC. It's the roughest way. Those vaccinations are very effective. About 90% of the people receiving such vaccines are protected, but it is the vaccine technology with the highest rate of side effects. The second step was not to use living microbes, but inactivated vaccines. Those infectious agents actually are dead, so they have no metabolism anymore. They cannot replicate. Actually, they cannot do anything, just show themselves to the immune system. This is something we use for cholera, hepatitis A, and the current polio vaccine. The next step then was to develop vaccines that do not need the whole virus or the whole bacteria, but only a small part of the surface of those microbes. So this is the so-called peptide or protein vaccination. This is common for diphtheria, pertussis. We do it with the tetanus vaccination, and this is the technique we use for most of the flu shots. So this is what we have done the last, 300 years almost. And now we have the genetic vaccines, DNA and RNA vaccines, and this has never been done before. We tried to do it, but all the candidates with this technology so far have failed, either because they didn't work or because they caused heavy side effects. So this is the first time we use this vaccination technology in large scale. The major difference between, let's say, the old ones and the genetic ones, and this is important for you to understand most of the side effects, especially this thrombosis stuff that we are facing right now. It has become popular with AstraZeneca, but it also occurs with Johnson & Johnson, and it occurs with BioNTech and Moderna. The major difference that causes those problems is that the old vaccines had a direct uptake by the APCs, the antigen presenting cells. With the genetic vaccines, they need to be taken up by healthy cells, not immune cells, can be any type of cell. Then this cell will rebuild the viral protein, the spike protein, and show it on their surface, which means in order to get the antigen, our immune system needs to kill the cell that took up the vaccine. Okay, this is a lethal business for our cell, and this can cause severe troubles, as we will see. So this is what we currently do with Moderna, BioNTech, AstraZeneca, Sputnik, Johnson & Johnson. Actually, the only corona vaccine relying on the old technologies currently is the Chinese one, Sinovac. They use an attenuated, inactivated coronavirus. With the peptide and protein technology, there is currently none of the big companies using this, and there is nothing in the pipeline at the EMA or the FDA. There is one crazy doctor in Germany that developed a peptide vaccine on COVID-19. He used also the spike protein. It seems to be very effective and safe, but unfortunately, he didn't register it in advance as a clinical trial. So currently he's a court trial. And let's hope he doesn't end up in jail. But the vaccine theoretically would be available and effective and safe. Well, let's take a look at this rolling review stuff. In normal times, you would have 4 phases, preclinical, phase 1, 2, 3, and they all would sum up to a total of at least 9 years. 9 years is actually the minimum that you normally need to get a new vaccine approved. And this is what we did with the rolling review. With the orange bars, you can see the duration of those phases in a normal approval process. With the blue bars, you can see the duration of the single phases in the current situation. So what we do is we learn on the fly. which is a huge problem because this rolling review cannot replace a phase 3 clinical trial. We have no standards for reporting side effects or adverse events. Actually, the doctors do not get a list of this is what you should be aware of and this is what you should report. So no one actually knows exactly what to report. The people that receive the vaccination are not monitored as closely as in a clinical trial. In a clinical trial, they will see a doctor at least once per month. They will get routine lab investigations. They will have questionnaires. They will have to do kind of a diary. So we will gather a lot of information. What we currently do with the rolling review is to send the people home without telling them anything. So whatever happens, we don't know. This means that the reported adverse events, the number of reported adverse events probably is much lower than what's actually occurring. We simply do not know. But as all those details are lacking, it definitely does not replace a proper clinical trial. Here you can see some newspaper articles. Unfortunately, German ones, I didn't have the time to collect English ones, but you will see the same in your home country. What we see in Germany is that since the beginning of the vaccination campaign, we have brutally increasing mortality in the elder people, especially in the age group 80 plus. Since we started the vaccination, the mortality in this age group increased. In some regions in Germany, it's six-fold higher than before the beginning of the vaccination campaign. This is seen in many retirement homes. When we do the vaccinations, a couple of days up to 2 weeks later, we have a lot of death reports from the retirement homes. But this is not presented in the major media or news channels. This is local newspapers, they report about it, but that's it. What's interesting for us is that those people die of completely different reasons. So there is not the one adverse effect that kills the patients or causes problems. There are multiple effects, and this means that there must be multiple mechanisms involved, and the specific background of the one receiving the vaccine seems to be very important. And we do not know much about the specific background causing risks for the vaccine. We can guess, we can have some good guesses, but we don't know by 100%. Another problem, at least in Germany, and I think it will be similar in other countries, is that if someone dies after receiving the vaccine, actually what we would need is an autopsy and a careful post-mortem examination. In Germany, this is not possible in most of the cases because the district attorneys and the courts do not allow it. And for funny reason, they say in the clinical trials, there is no sign of lethal side effects. Therefore, there is no reason to examine people that died after the vaccination. And our officials claim that no death reports have been done from people dying after the vaccination. And of course, it's impossible to write such a report if you are not allowed to examine someone who died directly after receiving the vaccine. So this also causes a massive lack of information. We have insufficient data from phase 2 and 3. So we have no defined criteria what to look for, how to monitor the patients. In Germany, it's like this. For the doctors, reporting adverse events is paperwork that is not paid. I talked to a colleague today. He does about 150 vaccinations per week. And he reports about 30% of the people have trouble after the vaccination. And I asked him how many reports he did file so far. And he said exactly 0. Because he doesn't have the time to do it and he doesn't get paid for it, so it's not happening. Therefore, what we know about adverse events is not even the tip of the iceberg. In Germany, it's like this: if someone dies after having tested positive on corona, this is always interpreted as death because of COVID-19. If someone dies after the vaccination, it's actually bad luck. There is no connection between both events. Well, this is the increase in mortality in the age group 80 plus for selected regions in Germany. What you can see here are different counties in Germany. The blue bars are death in this age group from January to December 2020. And the orange bars are death in this age group since begin of the vaccination campaign, end of December. So in those 2 months, this is a report from end of February. In those 2 months, we had 6-fold more death in this age group than in the whole year before beginning of the vaccination campaign. That's massive. The problem that I can see here in Germany is that especially the older people are not informed properly. So we do not explain to them about the possible risks or benefits of the vaccination. Actually, we simply give the shot. That's it. We also do no proper risk assessment. As you will see in the clinical trials done by BioNTech, Moderna, and AstraZeneca, they excluded the risk groups from the clinical trial. So if we talk about people, let's say 75 plus with pre-existing diseases, we have no data from the clinical trials at all because those people were excluded from phase 1, 2, and 3. Let's take a look at the production of the vaccines. We start with the viral RNA. This viral RNA is being transformed into DNA. So this is a completely artificial product. This is not a genome that exists in nature. We create the DNA, and from those DNA, we can make copies, and those copies can be used to directly produce the DNA vaccine, or we can transform it into mRNA, and those mRNA copies then are used for the RNA vaccines. Both are based on artificial DNA. So it's not like reported in the media that we take the original genome of the virus and put it in the vaccines. This is a completely artificial genome. Either DNA or RNA, in the end, we want to get the spike protein. Now, this is what happens with a natural infection. The virus will enter the cell, then we'll set free the RNA, the genome. This will be translated by our ribosomes. We will build the viral replicase and replicate the RNA. We will build new proteins and then assemble the new viruses so they can leave the cells. As you can see in this image, and that's important, the nucleus is untouched in this whole process. And that's the difference to the vaccines. The DNA vaccines, AstraZeneca, Johnson & Johnson, and the Russian one, Sputnik. When you bring the DNA into the cell cannot read this DNA in the cytoplasm. It needs to be transformed into mRNA. And the enzymes to do so are only present in the nucleus of the cell. This means you have to transport this viral DNA into the nucleus next to our DNA. Then it can be transformed into mRNA, or you do it like BioNTech, Pfizer, and Moderna. You give mRNA directly. mRNA does not need to enter the nucleus. It can be translated into a protein directly in the cytoplasm. What's important to know is after the cell has used the viral genome to assemble the protein, the normal way, if there is a strange protein inside the cell, is that the cell would present this protein to the lymphocytes using the MHC receptor complex. This is not what happens with the spike protein. The spike protein contains a codon that tells the cell that this is a membrane protein. So instead of putting the spike protein into the MHC complex and showing it to the lymphocytes, the cell integrates the viral protein into the cell membrane. So from the perspective of our immune system, our cells are now identified as a virus. And in order to get this spike protein, in order to get this antigen surface, our immune system needs to kill the cell that has built the spike protein. I'm rather surprised about this because it wouldn't have been a huge problem to remove this codon classifying the protein as a membrane protein. If they had removed this, then the spike protein either would be excreted outside of the cell or it would be put in the MHC complex. This would be safe. But the companies decided to make it a membrane protein. Now let's see how we get the genome into the cells. With both RNA and DNA, we have a huge problem because if you inject them to the body, they would very soon be degraded and destroyed by enzymes. So in order to prevent this, we have to use some kind of carrier. With the RNA vaccines, this carrier is a nanoparticle coat built of lipid nanoparticles. Now, the lipid nanoparticles are our first concern because they are made of PEG, polyethylene glycol. This is a very common xenobiotic substance. You have it in lots of products, especially shampoos and stuff like that. So many people have already been in contact with this substance, which means there is a discrete allergic disposition in the population. Now, normally, if someone is allergic to PEG and uses a product containing PEG, it will irritate the skin. You will use another product, end of story, nothing bad has happened. But in this case, it's not a topical application, it's parenteral. And this means that there is a significant risk for anaphylactic reactions. In the UK, the officials, after some time, recommended that patients with heavy allergic disease should not get the vaccine, or at least get the vaccine only under medical supervision. So you could do an intervention in case of anaphylactic reaction. Another problem is that those nanoparticles have a toxicity because they can interact with our own proteins. This has acute toxic effects, and in long term, it can induce autoimmunity. The last concern I have is that the nanoparticles do not target a specific cell population. Actually, they can enter any kind of cell. This comprises stem cells and neurons. And we do not know what happens if the nanoparticles, if the viral genome enters those cells. We will see. In 2 or 3 years, we will know what happens. BioNTech did a safety assessment of the nanoparticles before starting phase 1. This has been published already. And what they did is to mark the nanoparticles with a radioactive substance, so they could see the distribution. Where do the nanoparticles go after the injection. And what they could see is that there is an immediate systemic distribution with accumulation in distant organs within 6 hours. Those organs comprise bone marrow, comprise liver, lungs, spleen, and kidneys. Okay. And please keep in mind that all the cells that take up the vaccine and build the spike protein will get killed by our immune system. The known toxic effects of the nanoparticles that could be seen in this animal model comprised inflammation, induction of apoptosis, fibrosis, a massive production of radicals, and an activation of fibrinogen. Now, if we take a look at those known toxic effects, then things like clotting, like hyperinflammation, like oxidosis are very likely to happen soon after the vaccination. There is a lot of literature because nanoparticles have been investigated since more than 20 years. We hoped to use nanoparticles, for example, in oncology to transport the drugs into the cancer cell instead of flushing the whole body with cytotoxic substances. But it turned out that nanoparticles are not easy to handle. So in this publication here, they took a look at the oxidative toxic effects coming from nanoparticles, and they could see that with systemic application, IV or IM, you get heavy reactions in the liver, in the heart, in the kidneys, and in the brain. Okay, and this we all did know before we started to produce nanoparticle-based vaccines. So we know that those nanoparticles accumulate in the bone marrow and in the brain, but this is not communicated. Now with the DNA vaccine, what's the approach here to get the genome into the cells? What we do is we use a viral vector, meaning it's a living, healthy, happy virus, and we insert the genome for the spike protein into this virus. Then we inject the virus into the patient, and in theory, this virus will be taken up by the target cells. They will express the spike protein, show it in the MHC1 receptor, and then stimulate the immune system. But we have the same problem here. As we use DNA, we do not only need to enter the cell, we need to enter the nucleus. And as this genome is still marked with the membrane codon, it will also not be shown on the MHC1 complex, but it will be integrated into the cell membrane. A possible problem with a vector virus is that the virus itself can cause immune reactions. So it might be that our immune system does not primarily react on the spike protein, but on the vector virus used for the vaccination. This might be one reason why the second shot in many cases causes more troubles than the first shot, because our immune system now responds to the viral vector. The Russians did think carefully about this problem, and for Sputnik, they decided to use different vector viruses for the first shot and the second shot. So you can avoid this immune response with the second shot. It's still an unknown vector virus. With AstraZeneca and Johnson & Johnson, they used the same virus twice. So the risk for inflammatory responses here is higher than with the Russian vaccine. Another problem that has been known for a long time, I mean, this is a publication from 2002, okay? It's kind of antique. And in this investigation, they checked whether certain adenoviruses that are used to create such vectors are able to integrate the genome that they carry into the human genome. And well, AstraZeneca, Johnson & Johnson tell us that's impossible. I do not agree. Since more than 20 years, we do know that those adenoviruses can do this insertion, and the likelihood for this to happen is between 1 out of 100 up to 1 out of 1,000. That's a whole lot. Yeah. So if you get a medical intervention that changes your genome with a likelihood of at least 0.1%, I'm not sure if you still would be very keen on getting this intervention. Yeah? And 1 out of 1,000 is the lowest rate for this to happen. Another problem that we had in the past with vector vaccines is that they can create so-called ADE syndromes. This is an antibody-dependent enhancement syndrome, meaning that there can be antibodies produced after this vector vaccination that do not show the typical function of antibodies. They do something different than attacking the virus. One thing they can do is to boost the uptake of the virus into our cells and therefore the replication. So if you have those ADE antibodies, the viral replication in case of infection will explode. Yeah? You will have a much severe clinical course in case of infection. And the second thing those ADE antibodies can cause is to activate our complement system, which causes an unspecific inflammation, mostly in your vessels. This might also contribute to the clotting problems that we see in people after the vaccination. So increased virus cell fusion, increased viral replication, and increased inflammation. This is ADE syndrome. Now, when is this likely to happen? If the body is facing an infection at the time you receive the vaccine, or if your body already developed immunity against SARS-CoV-2, and then you receive the vaccine afterwards. In the clinical trials, phase 1, 2, 3, the companies have been very careful to exclude people that already had contact to the virus. Everyone with a positive PCR was excluded from the clinical trials. And this is something we do not do in the ongoing campaign. Yeah, we do not check whether someone already had contact with SARS-CoV-2 or not. We simply do the shot and fingers crossed it will be fine. An example for a DNA vector vaccine is a vaccine developed by Sanofi. It was intended to protect from dengue fever, and they used it on the Philippines, but not for long. Within 1 year, they had to stop the vaccination and retract the vaccine from the market because it turned out that people with the vaccine had much more severe disease in case of infection than people that have not been vaccinated. The Philippines were quite unhappy with Sanofi and tried to court trial them, but guess what, it didn't work out. But anyway, this is one of the rare cases where we tried to use a vector vaccine in practice, and what we saw was a massive ADE syndrome, those antibody-dependent enhancement. And I think this is the reason why we see an exploding mortality in those groups that have received the vaccination so far. You can take a look at mortality and vaccination rate in many, many countries, maybe Israel, US, Denmark, Norway, the UK, Germany, whatever. After starting the vaccination campaign, you will see an increasing mortality in the groups receiving the vaccine, not of COVID-19 necessarily. Another vaccine that was developed was a DNA vaccine against HIV. It was developed in the UK. Guess what? It didn't work. So the rate of infection in the vaccinated people was higher than in the control group. And the researchers that conducted this clinical trial, they published a paper in Nature after they saw what's going on with the vaccination development, when they saw that the companies were focusing on genetic vaccines. They thought back to their experience with genetic vaccines in HIV, and they published this paper and urgently warned for this ADE syndrome if we do a vector vaccine against SARS-CoV-2. This was published in Nature. The data is solid, yeah, but actually no one did take much notice from it. Now let's take a look at the clinical trials provided by BioNTech and AstraZeneca. For the following diagrams, we used the same classification that the companies used. So mild adverse effects mean spontaneous improvement, no intervention required. For example, some itching at the location where they received the injection. Moderate means that they needed some sort of intervention, but low level intensity, for example, some painkiller or some fever medication, but it could be done as an outpatient consultation. Severe is something different. Severe means that normally, if this is a clinical trial, you have to interrupt the protocol. The patients need to go to hospital or require inpatient care and rather invasive procedures. So severe is not having some headaches or feeling a bit tired. Severe is severe. And then we have serious. Serious means it's a life-threatening event requiring emergency procedures. What you can see here is data from BioNTech from phase 1. Yeah. We have the age group from 18 to 55. The upper diagram shows adverse events after the first dose, the lower one, adverse events after the second dose. Now, if you take a look, the rate of adverse events is rather high. With fatigue, headaches, we have a rate of 40 to 50%, and among them already severe, yeah, meaning they go to hospital and require intervention. And those symptoms get worse after the second dose. Here we have rates of up to 75% of people reporting adverse events, and again comprising severe level. Severe level is especially seen with neurologic symptoms, so fatigue and headaches. This is the same assessment, but for people between 65 and 85. And as you can see, the rate of side effects is lower. This is mostly due to the fact that older people have a weaker immune system. So the response to the vaccine in general is lower than in younger people. And in this case, it's some sort of advantage because the rate of adverse effects also is lower. This is a very interesting chart showing the immunity induced by the vaccine. On the left, we have the young participants. On the right, we have the old ones, 65 to 85. Now take a look at the level of immunity. This was measured with an antibody assessment. Take a look at the level of immunity with the different doses. So we have 3 columns each, 10, 20, and 30 microgram of vaccine applied on the participants. And what you can see here is that the level of immunity does not differ significantly between 10, 20, and 30 gram. So based on this diagram, there is no reason to use 30 microgram for the vaccination because you have as good results with 10 and 20. This is one point. And the other point is, if you take a look here, BioNTech measured antibodies on the day of the first dose. They measured it on day 21 before they applied the second dose. And then on day 28 and day 35. What they did not do is to make one group that received only one shot. So from the very beginning, they only use protocols relying on repeating the vaccination. They only checked immune responses with 2 injections. They never checked what's happening with 1 injection. And they also didn't check if there is an immune response with less than 10 microgram. So what BioNTech did based on this data from phase 1, they started phase 2 with a dose of 30 microgram and with a 2 injection protocol. And for me, this is not rectified by the data. 1 shot wasn't examined at all. And even with 2 shots, the immunity with 30 microgram is not significantly better. Next thing is those 95% efficacy that you always hear in the media talking about the vaccine. This number does not mean that you are protected with a probability of 95%, not at all. What this number means is the following. In phase 2, BioNTech had 36,523 participants. Among those, they had 170 cases within 4 months. So much about the dangerous pandemic. 170 in 4 months out of 36,000. Now, from the risk groups, so people with certain diseases, people older than 75, they had 13 cases in those 36,000, which means 99.6% of the patients had no disease at all, no matter if they got the vaccine or not. And the cases comprise people that only had a PCR positive result. So cases does not mean clinical symptoms of COVID-19. The absolute risk reduction, so the percentage to get COVID-19 for the individual was lowered by 0.4%. Yeah. So it's like that. Without the vaccine, you will stay healthy with a probability of 99.99%, and with the vaccine, and without the vaccine, it will be 99.6%. So the individual absolute risk reduction is 0.4%. Now, with 0.4% protection rate, but a risk for severe adverse events of 1.1%, and for serious, which means life-threatening, according to the data from BioNTech, I think this is not a proper risk-benefit ratio. Here you can see the abundance of adverse effects. We have grade 1, 2, 3, so mild, moderate, and severe. Now take a look, grade 1, we have numbers of about 60% of the people showing adverse events. With grade 3, meaning severe, so this requires to go to hospital, this requires intervention. You have a rate of 6.2% in younger and 3.8% in older people. What's interesting is that you see rather high numbers in the placebo group. They also have a rate of 2.4% severe side effects. This is not what you would expect from a placebo. Now the point is they didn't use a real placebo. What BioNTech did is they used lipid nanoparticles as placebo, just without the viral genome. So what you see here in the placebo group is simply the toxic side effect from the
Ich
nanoparticles.
bin hier noch in so einem Webinar, ein ganz interessantes, blöderweise.
Someone has turned on the microphone.
I have to turn it out again.
Okay. With life-threatening, so serious, they had only 11. I think 11 is already pretty much in 36,000. All of them were cardiovascular. This fits to the Italy experience. There, two health workers, a doctor and an assistant, died after the vaccination from heart arrest. Both had no pre-existing disease. The Italian officials denied an autopsy because they said there is no data to rectify this. The severe adverse events were seen in up to 19.6% of the subgroups. The average of all subgroups was 16% with systemic adverse events, so not the local ones on the injection side. And interestingly, they also found persistent adverse effects that lasted for more than 28 days. Now take a look at those persistent adverse effects. A total of 23.9% of the participants reported ongoing side effects for more than 1 month. And again, the highest rate is seen in the nervous system, followed by the muscle and skeletal system. Then we get respiratory organs, digestive organs, and fatigue in 2.4%. In the whole phase 2 study, there were 131 participants with more than 80 years. And of those, only 41 received the vaccine. So what we do now is to vaccinate millions of old people in Europe based on the data of 41 participants in a clinical trial. This is not the way we should do it in my eyes. In all participants of phase 2, they had 30 cases of severe COVID-19. And now take a look at the comparison. Placebo and vaccination group. So pneumonia in the control group with placebo, we had four patients in 30,000. Vaccination, 0. ARDS in the placebo group, 2. Vaccination, 0. Invasive oxygen intubation, we had 1 in the placebo, and ICU, 1 in the placebo and 0 in the vaccine group. So the total effect from the vaccination in 30,000 people was that you have 1 ICU case less. That's also interesting for the risk-benefit calculation. Let's take a look at the first experiences with BioNTech. You should closely follow what's happening in Israel. Israel is kind of a large lab for BioNTech because they use BioNTech only. There is no other vaccine used in Israel. They have the highest portion of vaccinated people. In the risk groups, they have vaccinated more than 80%. In the total population, more than half of the population. And Israel is very good in motivating the people because without vaccine, you get no green pass, and actually you cannot do much, only sit around at home. So if you want to have an active life, if you want to go to work, shopping, and so on, you need the green pass, and for this you need the vaccine. Now take a look about the numbers in Israel. This is the number of daily confirmed COVID-19 deaths. And take a look at end of August, beginning of September, after Israel issued a very strict lockdown, really strict. It's like prison. That's really lockdown, not some soft restrictions like here in Germany. It's real lockdown. After the lockdown, the numbers exploded. And then 2 months later, the numbers decreased and they reached a very low level. And then Israel started the vaccination campaign. This happened around Christmas, end of December. And now take a look at the incidence of COVID-19 death in Israel. After the vaccination, the number rises from 15 to almost 70. So we have fourfold more COVID-19 death after starting the vaccination. Now, as you can see, the numbers are falling now in March. So 4 months after the vaccination campaign started, the numbers go down. And this is interesting because not only the reported numbers of infections and death is going down, what's also going down is the number of tests performed. So the falling incidence, perhaps, we do not know, but perhaps the falling incidence is not because of the vaccine, but because they reduced the numbers of tests dramatically. Yeah, they cut it by almost 50%. Who knows? This is from the USA. This is data collected with their reporting system for adverse events after vaccination. It's a very interesting database, VAERS, that's the name. But I have to warn you, it's not easy to gather data from this database. It's very sophisticated and you have to get deep into it to be able to get the numbers. But anyway, take a look here at the numbers of reported severe adverse effects after vaccination. It's the total number of adverse effects per month in all the USA. Now, January 20, you start with 7, and it always is somehow between 0 and 15. And now look what happened starting in November. This is when they started the vaccination campaign with BioNTech and Moderna. The number of reported severe adverse effects, this is only severe, explodes from 4 in October to 638 in December and almost 650 in January. In February, we have lower numbers, but please keep in mind that in February, we have less days. It's that simple. Yeah. So you have 10% less days, therefore you have some less reported adverse events. This is the abundance of adverse events after injection with AstraZeneca. So this is the phase 1 trial from AstraZeneca. Blue is mild, orange is moderate, gray is severe, and yellow is all together. Now take a look at the rates. With some group of symptoms like fatigue, headache, nausea, shivering, you have a total rate of adverse events of 50 to 70%. Now, if we only calculate the severe ones, you still have numbers of up to 8% of the participants reporting severe adverse events. This is the comparison between the AstraZeneca COVID-19 vaccine. This is the orange bars, and blue, the placebo. And as you can see, AstraZeneca is a lot worse than the placebo. With severe adverse events, we have up to 8% in the intervention group and a maximum of 1% in the placebo group. And guess what? AstraZeneca also didn't use a proper placebo. Instead of injecting saline, they used a vaccine against meningococcus. So a vaccine used to prevent meningoencephalitis. And this is a rather nasty vaccine. Of course, they did so to make the intervention group look better, but even this was not enough to make it look good. Even if you compare the COVID-19 vaccine with an existing vaccine, you still see a lot more adverse events, especially serious ones. Another point is the duration of the immune response. Here you can see the concentration of neutralizing antibodies that AstraZeneca measured in phase 3 of their clinical trial. Now you can see that after 14 days, this is number 1, the antibodies start to rise significantly with a maximum after about 30 days. This is 0.2. And then in the follow-up after 56 days, you see that the number is rapidly falling again. The consequences for immunity are mostly unknown. And please keep in mind that antibodies are not sufficient. They only eliminate the virus outside of the cells. Okay, so if you have a low concentration, the virus might be able to make it into the cells, and then you cannot fight it with antibodies. Means there is still a certain chance for getting an infection, carry the virus, and develop disease. In the end of phase 3, if you read the final comment of AstraZeneca, they write in their own paper, their own words. Also, there were many serious adverse events reported in the study. In view of the size and health status of the population included, there was no pattern of these events that provided a safety signal. This is one of the possible interpretations of those numbers. It's not my interpretation. What else did happen in the phase 3 of AstraZeneca? They had 3 cases of transverse myelitis, 2 in the vaccine group and 1 in the placebo group, but the 2 in the intervention group occurred within 2 weeks after the vaccination. The 1 in the placebo group occurred 2 months after using the placebo, which means the transverse myelitis in the intervention group was directly related to the vaccine. The transverse myelitis 2 months after the clinical trial, in my eyes, has no meaning. Actually, the risk to develop transverse myelitis normally is 1.35 to 1 million. The risk in phase 3 with AstraZeneca turned out to be 1 out of 6,000. But for AstraZeneca, this is no concern. This is no warning. In my eyes, a 100-fold increase of transverse myelitis definitely is a warning. What else could they see? 12 participants developed a so-called vaccine-associated enhanced respiratory disease, which means it's mostly due to an antibody-dependent enhancement syndrome. We do not know because AstraZeneca did not investigate this in detail. A rate of 12 out of 12,000 in my eyes is massive. So the risk for this ADE syndrome, which is life-threatening, based on the phase 3 trial of AstraZeneca, is 1 out of 1,000. That's pretty much. And we are talking about young and healthy participants. This was not done in elderly people with a lot of pre-existing disease. But this is how we use it right now. Okay. The risk for severe disease in young and healthy people is much lower than 1 out of 1,000. Yeah. Actually, it's 5 out of 10,000. So the risk for severe adverse effects from the vaccine is much, much higher than the risk for severe disease in healthy people younger than 55. What else do we know? If we take a look at COVID-19, the clinical course of disease, then we can see that venous and microvascular thrombosis and disseminated intravasal coagulation, DIC, occurs in about 30% of the hospitalized patients with COVID-19. So obviously there is something about this virus that allows him to activate coagulation and to activate platelet aggregation. What we know from people with severe disease, from people in hospital, is that they show high levels of D-dimer, fibrinogen, and a prolonged prothrombin time. What else do we know? About half of the critically ill patients, half of the patients in ICU with COVID-19 develops phospholipid autoantibodies, especially antibodies against cardiolipin, but also other phospholipids. This comprises, for example, the heparin receptor. Those autoimmune antibodies against our own phospholipids are predominantly in COVID-19 patients with severe disease, with about 48%. So about half of the patients with COVID-19 in critical disease develops those auto-antiphospholipid antibodies. Interestingly, the concentration of those autoantibodies was not associated with the typical markers for thrombosis. So this is a different mechanism, okay? On the one side, we have activation of the platelets. On the other side, we have those antiphospholipid antibodies. What could be shown is that the patients with those phospholipid antibodies also had highly increased ANA. ANA is something that you can easily measure in your patients. Yeah? It's a very common marker to investigate autoimmunity in a patient. What we also could see in those critically ill patients is increased calprotectin. Those who had those antiphospholipid antibodies had increased calprotectin, and calprotectin also is something you can easily measure. It's an easily available parameter, much easier than anti-phospholipid antibodies. This is sophisticated. Most of the labs you work with will not be able to measure the anti-phospholipid antibodies, but they can measure ANA and they can measure calprotectin. And if you see that those two are going up, then you have a very high risk for those atypical thrombosis that we see in people after the vaccination. What you also could see is myeloperoxidase DNA complexes, the so-called NETs. It's a very, strange way of immune response. Actually, the neutrophils kill themselves and throw their DNA like kind of a net on the virus. This is a desperate measure. Yeah, this is not something the granulocytes will do all the time. Only if there is no other option left. Yeah, it's the last full measure. What we also know from COVID-19 patients is that they show a lot of endothelial inflammation. And endothelial inflammation is something that is very common in a lot of people, especially people older than 50, especially people with pre-existing morbidities, like any type of cardiovascular disease, like obesity, like diabetes, like rheumatic diseases. They often have endothelial inflammation. What we could learn from applying the vaccine and what is special about the genetic vaccines compared to the traditional vaccines. Normally, if you have a natural COVID-19 infection, the virus is located in the lungs, in the respiratory organs. But normally, the virus does not get into your bloodstream. This will only happen in case of critical disease. But normally, the virus will not enter your bloodstream. Now, what we do with the vaccinations is to induce spike protein in the bloodstream instead of the lungs. This is a major difference to the natural infection. The second one, as I told you in the very beginning, is that the vaccine is working inside our normal healthy cells and becomes a membrane component. This also does not happen with the natural spike protein. It's also far from the natural situation to use a single protein instead of the complete viral code. Now, this will raise issues with the ongoing mutations. If our lymphocytes are trained with the complete code, or let's say a major fragment of the complete code, they can develop a so-called pan immunity. So they will identify different targets on the virus. So if one of the targets changes because of mutation, our immune system is not thrown back to zero. It still can recognize the virus. Now, if we use only the spike protein, and if there is a mutation changing the spike protein, then our immunity from the vaccination is very low. And this is something we can already see. In Germany, everyone's concerned about the UK mutation and the South Africa mutation and the Brazil mutation and whatever. And what we can see is that vaccinated people are not highly protected from those mutations. So it's very likely that we will have to adopt the vaccines and do another vaccine campaign. Yeah, it will be like the annual flu shot, just for everyone. The flu shot was optional. The COVID shot will become mandatory. In Israel, as they have already vaccinated the majority of their population, they still have high numbers of infection. So Israel already issued a plan to repeat the vaccination twice per year. Yeah, so they will vaccinate all their population every 6 months. Now, if you remember that the spike protein becomes part of the cell membrane, imagine this is an endothelial cell. Then your immune systems rolling along the endothelium will discover the spike protein and attack the endothelial cells. And then you have an inflammation inside the wall of your vessels. So your endothelium becomes a primary target. And it's very likely that the endothelium will take up the vaccine because after we inject it, if you remember, we have systemic distribution within 6 hours. And this distribution is happening through your bloodstream. And the first cell population to get in touch with the vaccine, that's your endothelial cell. It's that easy. So we shouldn't be surprised about endothelial inflammation and all the possible complications coming from this. Stop. This was the wrong slide. One moment. Another problem. This was discovered by the PEI in Germany, the Paul-Ehrlich Institute. It's our government institution that monitors the safety of vaccines. They discovered that the spike protein, if it's shown on the membrane of our cells, can work like a magnet. If you have two cells with the spike protein on their surface, they will get attached to each other and you will see a cell fusion. So after the cell fusion, you will have kind of a gigantic monster cell. They have observed this with more than 100 cells, making a fusion and building such a monster. Inside this monster, you have all the genome, all the nuclei from the original cells. Now, what will happen to those monster cells after the cell fusion? We don't know. No one investigated. Best case, they will die. Nothing happens. Worst case, if you have a lot of genomes in the same cell, maybe the cell gets confused. This might be, for example, a risk for cancer processes in the future. We can discuss this again in a couple of years, then we will know. Right now, we only know that this process is happening. Now, this is this endothelial inflammation. As you can see, number one, your endothelial cell takes up the vaccine. Number two, it expresses the spike protein on the cell membrane. Number three, a leukocyte gets attached. Number 4 and 5, the leukocyte will attack the endothelial cell. It will start an inflammation. Number 6, as you can see, this inflammation will attract platelets. Yeah. They will accumulate and aggregate. And number 8, worst case, this platelet aggregation will start to move, and then you have thrombosis. Now, these are numbers from the PEI in Germany, so the reported adverse events in Germany. Now, if you take a look, we have blue, all kind of adverse events that have been reported related to a vaccination, all kinds, all levels. Now, orange is only the severe adverse events. Now, on the left, the 3 bars on the left are accumulated data in Germany from the last 20 years. So all reported adverse events severe, and death within 20 years. On the right, the 3 bars show the same number, but only for the corona vaccines within 3 months. 3 months. So if you take a look at this proportion, it becomes evident that we get a lot more adverse events from the corona vaccine than from all other vaccines taken together. You can see this here. Blue is the average number of reported adverse effects from all other vaccines. Orange is only the 3 corona vaccines, AstraZeneca, BioNTech, and Moderna. This is the ones we use in Germany. Now, if you compare the monthly average from the COVID vaccines with the other vaccines, you can see that there is something wrong. There is something really wrong going on. The numbers exploded. We have 60 times more reports about adverse events than before we started this vaccination campaign. This is the relative abundance. So which proportion of the vaccinated people shows adverse events? Now, blue, again, we have all vaccines. Orange, we have the COVID vaccines. And it's the same situation. You can see that the numbers with the COVID vaccines kind of, exploded. We have reports on severe adverse effects in 0.35% of the vaccinated people. That's a whole lot. Yeah, that's 1 out of 300. This is, we wouldn't accept this for any other kind of intervention. Perhaps a chemotherapy, there we would accept it. But for a vaccine, normally not. Now, some people say, of course, the number of reports is going up because we do a lot more vaccinations than we did before. Actually, this is not true. If you take a look here, the blue bars are all other vaccines. The red bars are the corona vaccines. Now, both are used in a similar number. Corona vaccines, we do 2.95 injections per month in an average. With all others, it's 2.96. So almost the same level. But also it's the same number of vaccinations. The number of adverse events is not the same. If you take a look at the severe ones, we have 47 all other vaccines. We have 1,002 for the corona vaccines. And it's the same number of shots. Also, in Germany, a lot of people are complaining that they only get AstraZeneca because AstraZeneca is so bad. It's so dangerous. Why do we not get the good stuff? Why do we not get BioNTech? At least it's a German product, so it should be available in Germany. But BioNTech Pfizer actually is a lot worse than AstraZeneca. Here you see the number of reported adverse events on the specific vaccines. Blue is BioNTech, orange is Moderna, and gray is AstraZeneca. And you can see the worst of all is BioNTech. The only thing that is much better in BioNTech is, I think, their public relations department. The clinical experience shows us that it's a lot worse than AstraZeneca, but AstraZeneca is having a very bad PR at the moment. So to summarize this, with the current vaccines, we lack proper clinical trials. That's why they have no regular approval. It's not only that we have new vaccines, it's about using a completely new technology for vaccinations. In my eyes, the data from phase 2 and 3 of the different companies, I showed you some of the data, raise severe safety concerns. And the rolling review does not replace a clinical trial, not at all. At least in Germany, adverse events are not investigated properly. There is no proper consent information provided before the vaccine, especially in the elderly people. It's a mess. Yeah, we do not thoroughly investigate their condition before the vaccination, and actually we do not care much about them after the vaccination. We do not check for a pre-existing immunity or a current infection, which dramatically increases the risk for this ADE syndrome, for this antibody-dependent enhancement. Nobody checks it. At least I haven't seen any publication in any of the countries doing this campaign about the incidence of ADE syndrome. It's like it wouldn't exist. And the first results show us that the vaccines do not provide a sterile immunity, which means you can still carry the virus, and worst case, you might still be infectious. Now, all those risks without getting proper immunity raises severe questions in my eyes. In Germany, it's a disaster. Yeah. Our politicians tell us that it's a patriotic duty to do the vaccination. In the mass media, we have a lot of comments like, make it mandatory. Whoever refuses the vaccination, he should be excluded from society, should be punished. The rights should be cut. And this is what's already happening. Next thing we will see is this vaccination passport. The EU already decided to make this come true by summer. We will get the digital passport, which will be necessary to travel. And it will not stop with traveling. I think this will be mandatory for a lot of different workplaces, especially in the medical field. I do not think that physicians or caretakers, healthcare professionals in general will be able to avoid the vaccination. Let's take a look at Johnson & Johnson. I will not present all the details because it's pretty much the same as what we saw before. In general, their phase 3 trial included 39,000 participants, and among them, they had 99 severe cases, so cases with pneumonia, and a total of 13 participants out of almost 40,000 had to be admitted to hospital. So the overall incidence of COVID-19 was 0.25%. 99.94% in the placebo group and 99.99% in the vaccine group didn't develop severe clinical conditions. Yeah, so according to the numbers, folks, where is the pandemic? Okay, obviously they were running out of clinical cases in this clinical trial. That's their major problem. If you take a look at the relative risk reduction, not the absolute, the relative, it's even worse than what we have seen with BioNTech. In the age group over 60, the relative risk reduction is 42%. In the age group over 75, we have no data because there were only 4 people in the whole clinical trial. Yeah. So again, the same thing. Those groups that have the highest priority to get vaccinated, almost no data in the clinical trials. Same with people with pre-existing disease like hypertension, for example. The relative risk reduction is 35%. Also about the sterile immunity. So within the first month after vaccination, only 12.5% showed sterile immunity. After 1 month, the sterile immunity could be proven in 59.7%, which is still bad. It's almost 50-50 whether you develop sterile immunity or not. But they also had some funny adverse events. With a rate of 1 out of 20,000, they had inflammation of spinal nerves. They had Guillain-Barré syndrome, yeah, which normally is not that common. The risk to develop this syndrome doubled for those who received the vaccine. They had pericarditis, they had this so-called post-vaccine syndrome. And this is a funny side effect from Florida. This person developed severe acute eczema. He needed to be admitted to hospital. He survived it. It was not life-threatening, but it was very, very uncomfortable. And this seems to be repeating. So might be that this is a specific characteristic of Johnson & Johnson. In the meantime, the FDA paused the use of Johnson & Johnson in the USA. So Johnson & Johnson delayed the rollout in Europe. Then the FDA approved it again. And now Johnson & Johnson delivers the vaccine to Europe. It was a similar story as with AstraZeneca here in Europe. The EMA took 48 hours to think thoroughly about this thrombosis stuff. Within those 48 hours, they didn't gather any new data. They didn't do any clinical trials or investigation. But after 48 hours, by surprise, they decided it's safe. And the same happened with the FDA. They took 3 days to think about it. And without having any further data, they said, well, it's safe. Congratulations. I think it's another topic, but with all those curves and diagrams of incidence, mortality, cases, and what on, if we take a look at them and we try to correlate it with lockdown or with vaccine campaigns, I think what we have to keep in mind is that there is a very strong seasonality in COVID-19. So what we observed so far is the numbers go up during the cold season and the numbers go down with spring. This is the same in pretty much all the countries worldwide. Yeah. Here you can see Germany, Israel, Sweden, and UK. Those 4 countries had 4 different strategies. Sweden had no lockdown at all. Israel had a very strict lockdown and a high ratio of vaccinated people. UK is kind of in the middle, but in Europe, probably the country with the highest rate of vaccinated people. But the numbers are higher than in Sweden. Yeah? And the highest number we have in Germany. So we are at least European champion in how you should not do it. But all countries show this seasonality. Perhaps 2 sentences about the mutations. These are the numbers in the UK. This is the country with the highest prevalence of the UK mutant. And as you can see, the numbers have fallen and remain low. This is South Africa, so the country with the highest prevalence of the South African mutant. Same story. So I am not that much concerned about those mutated versions of SARS-CoV-2, but of course, the the vaccines will not provide sterile immunity against the mutants. So what we will see is a continuing vaccination campaign at least once per year to keep up with the mutations. And honestly, to use an experimental vaccine once per year in hundreds of millions of people, I'm lacking the words to express my feelings about this. Now, let's talk about what to do in case you cannot avoid vaccination, or in case you have a patient or a customer or a relative who insists on doing the vaccination. What can we do to decrease the likelihood of severe problems? First of all, check the immune status. Rule out existing immunity, so perform a check for specific T lymphocytes and for specific antibodies. If there is immunity, do not do the vaccination because the risk for ADE will be very high. Rule out an ongoing infection. So before receiving the vaccine, a PCR should be done. And if there is a positive result with less than 26 cycles, cancel the vaccination. It's not necessary, it's dangerous. Rule out a silent inflammation because the risk for those hyperinflammatory side effects will be much higher than in the average. This can be done with a cytokine profile. Here you can see such an immunity profile. This is done by BioVis in Germany. They were one of the first to establish a comprehensive immunity profile on SARS-CoV-2. You can see antibodies, IgG, IgM, and you can see the specific T cell immunity on SARS-CoV-2, but also the pan immunity on the whole family of coronaviruses. So in this case, you see a typical result. The antibodies are negative, but there is a strong T cell immunity against SARS-CoV-2. So this is not a candidate for a vaccination. This person doesn't need a vaccination. And in case this person will perform a vaccination, we have a rather high risk for this ADE stuff. Here you can see a typical cytokine profile. In this case, we have high interleukin 2, high interleukin 6 and 4. So this patient is suffering of a chronic silent inflammation. And to induce an immune response on a genetic vaccine under those conditions, risky. I wouldn't do it. Second thing to do, if you find it, keep inflammation and radicals low. What you can do is to check the glutathione ratio, so the ratio between reduced and oxidized glutathione. If it shouldn't be in perfect range, use NAC or ACC, so acetylcysteine, but use it in a proper dose, 100 milligram per kilogram body weight. Yeah, this is the minimum. This is the minimum. Check for ox-LDL, lipid peroxides, nitrosative stress, and in case of positive results, use polyphenols, use antioxidant, especially vitamin C, because vitamin C is pretty effective in your vascular system. It's rather useless inside your cells, but to protect the endothelial cells, vitamin C is pretty perfect. So here is a bunch of products that I currently use. It's not about recommending specific those products, but as I work for Mitocare, of course, I often use their products. You can use similar. It's just to give you an idea of which micronutrients could be used to provide risk reduction. So polyphenols they are very good in reducing those pro-inflammatory cytokines. The silent inflammation is a very potent combination of anti-inflammatory herbals, vitamins, and micronutrients. So it's very good for those with a chronic silent inflammation. The antioxidants, just a mixture of the typical candidates. In case of increased cytokines, I would strictly recommend to use polyphenols. If it's about radicals, it's better to rely on a mixture of antioxidants. So glutathione, vitamin C, vitamin E, all that stuff. Do a proper combination. Do not rely on one antioxidant. All of them should be given in case of cardiovascular risk. Okay. Then, of course, make sure that vitamin D is doing fine. Sufficient levels of 25 OH should be higher than 50 micromole. Check the vitamin D ratio. So the ratio between 1.25 OH and 25 OH, it should be lower than 1. If it's higher than 2, you have an ongoing inflammation and shouldn't do the vaccination. If you find a high vitamin D ratio, you can use our protocols, which is a combination of vitamin D binding protein, the big immune, and the vitamin D regulator. Or you can use a prescriptive drug, olmesartan. It's used against hypertension, but it's also very good in restoring the vitamin D ratio, the vitamin D receptor function, and it's available everywhere. It's no problem to get it. Also, do yourself a favor and closely monitor coagulation, platelets, and endothelial status. So after vaccination, tell your patients to come in to monitor D-dimer, fibrinogen, the platelets, the partial thromboplastin time, high sensitive CRP, and interleukin 6. And in case you should see that one or a couple of them are significantly going up, be warned. Then you have to do anticoagulation. Yeah, use a lot of vitamin C. That's the minimum. You can use salicylic acid, aspirin, or if you get a strong rise, take heparin. Yeah. Heparin will work, just not in case it's a candidate with antiphospholipid antibodies. Then heparin is useless. To rule this out, you could measure ANA, calprotectin, or if possible, of course, the antiphospholipid antibodies. Then heparin will not work. You have to think about different procedures to stop coagulation. If you have an MD with a very high compliance, you could try the following. Reduce the dose of the vaccine by 50%. According to the data from phase 1, this will still work pretty good. Yeah. AstraZeneca did it by accident. Yeah, they reduced their dose by 50%, not willingly, they just did it, but now we know that 50% less works better than the 100%. With BioNTech, Pfizer, and Moderna, they didn't try lower doses, but at least down to 10 milligram, we know it still works. So if you have a very nice MD with a high compliance, talk to them, reduce the dose by 50%. By reducing the dose, of course, there is a higher risk that the immune response will be pretty low. What you can do to support immunity with a low dose vaccination would be to use nucleotides. You can see here an investigation that was done in a group with vaccination 2 times, 2 shots on day 14 and day 24. And the yellow line is the concentration of antibody in the control group. And the green line shows the antibody concentration in the intervention group that added nucleotides. And as you can see, the antibody response comes much faster. It's 50% faster. And the concentration of antibodies is 70% higher than in the control group. So this might compensate for the use of a lower dose. Faster, higher, and with the lower dose, you have less toxicity. What else can you do? Well, of course, keep fingers crossed. Yeah. I think this is very important. Think positive. Might sound stupid, but it becomes more and more important. At least for those in Germany or speaking German language, there will be a publication in the upcoming month, I think by July. I did write a book on all this COVID-19 stuff, how to do coronavirus. In this book, I will take a look at all the different topics of the pandemic. Yeah, the virus, the testing, the vaccines, the lockdown policy, but half of the book concentrates on practical things, what to do. How can we prevent infection? How can we prevent disease after infection? What can we do for children? What can we do in case of severe disease? Yeah? How can we reduce the risk from vaccinations and so on? So I think by July it should be published. It will have almost 600 pages, but don't be afraid, almost 200 pictures, so it's not that bad. With almost 400 references, so you will have plenty of opportunity to do your own research and reading. I decided to publish it under my real name, so fingers crossed this will work, and I will still be able to do my stuff next year. We will see what happens. Right now, it doesn't look good. The public opinion, the published opinion, what our politicians do and think about the vaccination, in my eyes, is going in a completely wrong direction. I hope I could provide you some useful information to get aware of certain risks, to identify risk candidates that perhaps shouldn't do the vaccination, or at least take preventive measures before they do vaccination. You will get the whole lecture of today as a PDF. I already discussed this with Corinna. So I will provide the PDF, I think, by tomorrow noon, and then you can get it per PDF. Please feel free to share this PDF with as much people as possible. Corinna will also provide a recording of this session, so you can also share the video. For me, it's important that we spread this information. If people are not aware of the risks and of what's going on, we will never have a chance to influence public opinion to be more careful with the health of all of us. Right now, the next thing that's coming up is a vaccination campaign for children. And yeah, in my eyes, that would be a complete disaster. Their risk to develop severe problems from COVID-19 are close to zero. And the risks associated with the vaccination, this is, yeah, it's unbelievable. So hopefully we can at least avoid our kids to get vaccinated, but for this, we need people to get aware of all this stuff. Okay, so that's it from my side, I think. Yeah, that's all. So if any one of you has some questions, now you would have the opportunity to ask or give a comment.
Florian, did you see it that there were some questions on in the chat? Do you want to go through them? Some
Yeah, I'm
were
just going
answered
through
already.
them.
If you stop screen sharing, then you can see the chat better.
So first one is about allergic reaction on the PEG, as most of us have been exposed to this xenobiotic already. How high would you expect the allergic reactions to this ingredient? Would high toxic load or methylation problems raise the probability for complications? Actually, we do not have a broad-based investigation on the level of reaction on PEG because we never ever used it with a parenteral application, never. So this is pretty new for all of us, but what we could see is that there is a high rate of allergic reactions to the vaccines. Not only to AstraZeneca, again, AstraZeneca has the worst PR, but also to BioNTech and to Moderna, as we cannot rely on any significant figures. We do not have those investigations. What you could do is to check PEG before the vaccination. So take a blood sample, okay, and then do a so-called degranulation test. So you put isolated leukocytes in a culture in the lab, then you add the PEG, and then you observe if there is some sort of reaction, like swelling of the cells, secretion of cytokines, whatever. Those investigations, in Germany at least, can be performed in Berlin with the IMD lab. Yeah. They provide this testing. So all you have to do is to tell them which xenobiotic you would like to see, or you can also send them a sample of PEG and then check for the allergic reactivity in a specific individual. This is the only thing to rule this out, as we do not have reliable numbers. So then there is an adverse side event monitoring. So, oh, yes, yeah, we have this. If the risk is only lowered by 0.4%, how can they promote that the vaccination campaign supports us to get rid of the virus that cannot work? Or did I misunderstand? No, that's absolutely correct. So without the vaccination, your personal risk to develop significant problems, so pneumonia or even birth, from COVID-19, if you are healthy and younger than 75, this personal risk is about 0.6, 0.5%. And after the vaccination, this is down to 0.1. So you have an absolute risk reduction of 0.4%. That's it. When they say it's 95% effective, this does not mean that you are 95% protected from the virus. It simply means that if you compare 100 vaccinated and 100 unvaccinated people, then in the vaccinated group, you will have 95% less cases. That's it. That's what they mean with 95% efficacy. And yes, it's impossible with this vaccination to get rid of the virus. Absolutely impossible. It will not happen. We will not be able to eradicate the virus with vaccination. No chance. If this was possible, we could have eradicated flu 20 years ago. Didn't work. So why not look for other solutions? That's absolutely correct. I tried to provide this with my book. As I told you, half of it is about concrete procedures for prevention, treatment, risk reduction. This is in the public discussion, no one talks about how to deal with COVID-19. No one talks about treatment protocols. No one talks about prevention protocols. All we talk about is lockdown and vaccination, nothing else. And that's cool. And you are right. I mean, right now we know a lot more about COVID-19 than we did 1 year ago. We know a lot more about the features of the virus, the features of the disease, about the risk factors, about the factors that drive the disease to progress to severe or critical disease. And we have tools. Yeah, we have tools to do interventions on this. It's all possible. The protocols are there. And yeah, we should use them. Absolutely. So, do you recommend vaccination of pregnant and breastfeeding moms? Which vaccine is the least dangerous for them? Sinovac. Well, Sinovac is, in my eyes, the least dangerous from what we know. But honestly, who knows? Who knows what the Chinese government allows to publish and what they do not publish? I do not trust them 100%. So there might be unpublished data that shows different problems with Sinovac, but at least in theory, if we take a look at the different technical approaches, at least Sinovac relies on a safe approach with a dead virus. No DNA in the nucleus, okay? No toxic nanoparticles, nothing. Not even a critical adjuvant ingredient. So from what we know and from the principles, yeah, Sinovac would be the best one. But guess what? Sinovac is not available here in Europe. And I do not think that the EMA will allow Sinovac to be distributed here. This will not happen. They will not open the door to this market for a Chinese company. Never, ever. If you want to get Sinovac, you would have to travel abroad. My wife, for example, she plans to visit her parents. She's from Thailand. So in Thailand, they use Sinovac. And she's thinking about getting a shot there instead of BioNTech or AstraZeneca here. But otherwise, it will be difficult to get it. If you cannot get Sinovac, you're in trouble. Pregnant or breastfeeding, I cannot tell you which is the minor evil. We are simply lacking the data to make any concrete suggestions regarding this. I mean, in the clinical trials, no one tested it on pregnant or breastfeeding moms. No one. We have no idea what could happen or might happen. So the best perhaps would be to find a doctor that agrees to do the shot with 25 or 50% of the regular dose. And before you rule out the problems that I mentioned, and in case of positive findings, you take the according procedures. This, I think, would be the best option if it cannot be avoided. Okay. Yeah, I think that's it about. Will you get vaccinated, Florian, if I may ask? No, definitely not. I will definitely not get vaccinated. For me, this is not the major problem. I mean, I can avoid it. I can live with the consequences. The big problem that I currently see is what will happen to my kids. I have 3 kids. All of them are going to school. And it will not take long. I guarantee you, by end of the year, we will have a law, at least in Germany, that allows kids only to attend school in case they are vaccinated. If you are not vaccinated, you will not be able to participate normal school. And this is a huge problem. I don't know what to do in this case. This is my major concern. For me, no discussion. I will not do it. There is no reason why. My personal risk to develop severe problems from COVID-19 is it's ridiculous. And the risk to develop problems from the vaccination is 100-fold higher. And we are only talking about acute adverse effects. This is what we have learned the last couple of months. We know nothing about long-term. I'm sure in 2 years we can do another session with funny long-term adverse effects. Who knows? Think of those monster cells, those fusion cells. Everything's possible. Everything's possible. This is something that never occurred in nature before. It's the first time this occurs on this planet. So then we have Maya ask a question about possible therapy. Of course. I mean, with the therapy, at least the ones who speak German. I did a lecture on COVID-19 prevention and treatment a couple of weeks ago. It is still available in our webinar. So if you go to the MitoCare website and you look for the academy for the trainings, after you register, you can enter the archive, and in the archive there is this lecture about prevention and treatment of COVID-19. Of course, this is not super detailed and it doesn't cover a lot of things, but at least to get a rough idea and to get an idea of the most common situations, you can take a look at this lecture to get some information. What do you think about ivermectin? According to the data we have, ivermectin seems to be a very good intervention if you have significant clinical problems with COVID-19. In Europe, a couple of universities did kind of a clinical trial with ivermectin, but they used it in asymptomatic cases or cases with mild disease. And guess what? They didn't find a benefit in ivermectin. Well, if there is no disease, how can a treatment be beneficial? But if you have severe disease or a high risk of severe disease, then you can use it very early. It's very safe. And according to the data that we have, it's pretty effective. There are some countries that heavily rely on ivermectin, especially in South America, and their mortality numbers dramatically improved after they started the ivermectin treatment. So yeah, it's easily available. It seems to be pretty effective. It has no large risk of major side effects. I think ivermectin it's a very good shot. Yeah. So perhaps, yeah, the problem with ivermectin is it's a prescriptive drug. Yeah, and not all of you will be able to get a prescriptive drug, but there is another option because ivermectin is also used for animals. So you can search online for ivermectin for your dog, your horse, your cat, whatever, and you will find a couple of online shops that provide ivermectin without prescription. It's just labeled for animal use, but it's the same substance you will get at the pharmacy. So yeah, I ordered it. I have some ivermectin here at home. Who knows? Perhaps someone in my family will have a problem with COVID-19. So far, no one, but who knows? And then it's good to have it because at least in Germany, you will not get it at hospital. This is something you have to do on your own. And after you get sick, it will be too late to order ivermectin online. So try to get some stuff now. Worst case, you have it. If not, throw it away next year. Okay. Looks good. I cannot see more questions in the chat box so far.
No, I think you covered everything. Thank you very much.
Okay.
Is there something you want to ask? Because now is the time. If someone wants to ask something, otherwise, I think I will thank you again, Florian, for this great presentation. I think it was amazing. A lot of great information, a lot to think about.
Yeah, definitely.
really ask everyone who's working with people who are interested in this, and just share this information. I will share the recording, and I think we all have people around us who ask questions about the vaccination, and I think this is something that should be shared. It's neutral information. Everyone can make their own opinion about what's going on, but I think this is something that needs to be heard. So please share it. I will do it definitely. So there's another message. Wait a second. One message. It's in German.
It's about the adverse events normally vanish after a couple of days completely. Question is, what about long-term negative effects? So, as I presented to you, a whole lot of participants in the phase 3 trials reported ongoing adverse effects for more than 1 month. How long? We do not know, because the companies stopped to record it after 1 month. They simply say, well, 1 month. If this will be 1 year or lifetime, we don't know. But the portion of people reporting ongoing adverse effects in total, local and systemic, all age groups, was 23%. And especially the nervous system was number 1 of the reported problems, with I think 4.5 or 4.8% of the vaccinated people reporting ongoing, long-lasting adverse effects. That's a whole lot. That's almost 1 out of 20 receiving the vaccine. And yeah, I think we will see a lot more of those ongoing effects. For example, with the nanoparticles, as I told you, they induce apoptosis, inflammation, and fibrosis. So, question is, where does this happen? If it happens in, let's say, the bloodstream, okay. If you're lucky, no clotting, no platelet aggregation, who cares? You will replace the cell, that's it. But let's say this happens in your bone marrow with a stem cell, or let's say this happens in your spine. Who wants to have fibrosis in the spine or in your brain? So if the damage comprises nervous tissue and nervous system symptoms were the most common reported adverse effects, damages in the nervous system probably will be permanent. Yeah? And I think in the future, we will also see an increasing number of people reporting CFS symptoms. In the adverse events reported in the studies, fatigue was the most common one of all adverse effects. I'm not optimistic that all of them will recover after a couple of days. I'm pretty sure that we will see a whole lot of people suffering of long-term effects, but I'm not optimistic that this will be covered officially. So it will be the same story as last time with pandemics. You remember narcolepsy in thousands of people in Europe, and there were court trials, and it took them more than 10 years to get at least some sort of compensation from the companies. And this time, the companies cannot be held responsible. When the European governments, when the European Union decided to buy the vaccine and distribute it for their people, they had to sign a contract with AstraZeneca, with Pfizer, with Moderna, that they cannot be held responsible for any adverse effects coming from the vaccination. So if the companies are not responsible, then you can sue your government. Good luck. That normally doesn't work. And the companies know why they insisted on such a contract. Okay. Yeah, that's it. I cannot see any more questions. So from my side, thanks for your attention. Take care, spread the information, I mean, spread it carefully. We have to be careful, but try to spread it. Okay. That's it from my side. Have a nice evening. Take care and goodbye.
Yeah, thank you. Thank you everyone for listening. Thank you, Florian, for presenting. And I think everyone's speechless right now, doesn't know what to do. So the point with the children actually, yeah, hit a nail. So I think we all need to think about what we're going to do. So thanks a lot. And the next meet and greet will be on a more positive topic, I promise. Have a nice evening. Thank you, everyone. Bye for now. Bye.